Now, I guess in contradistinction to Laurie and Dennis, I did come to this from a position of pain. I've always felt that knee replacement is a painful procedure, and it's got a reputation as a painful procedure. Patients tell me when you sort of suggest to them knee replacement, they say, "Oh, I don't know, I've heard that's really painful," and you get patients who just simply refuse to have the operation because of their fear of pain. Relatives tell them. Some patients don't come back for the second side if they've had an unpleasant experience for the first one. So excessive post-operative pain is an issue, and it does lead to patient dissatisfaction. And then it has further overreaching problems. It reduces mobility in the post-operative period and delays discharge. Something else that I think is important and often forgotten in knee replacements, we do have these patients who have ongoing pain after knee replacements, that small percentage of patients who are never happy. And there's certainly some evidence that patients who have severe post-operative pain or poorly managed post-operative pain are more likely to develop persistent post-operative pain. So I think getting adequate pain control is important for that reason as well. And so when we look at the options for pain relief that are out there, and I've used all of these, they all have their problems. Opioids, obviously, post-operative nausea and vomiting, and confusion, constipation, and it delays mobilisation because they're too sedated. I have used epidurals. I work at St Vincent's, the home of regional anaesthesia, and they were very keen on epidurals. But they're very labour intensive. They slow mobilisation. Hypotension, so they've got to be really monitored, and potential for epidural hematoma, which is a catastrophic complication. So recently we switched to femoral nerve blocks because they said they would give equivalent analgesia, but they're time consuming. I've sat there sort of 10, 15, 20 minutes while the anaesthetist is fiddling around trying to put in a nerve block. There is an associated risk of nerve injury. I've certainly had patients come back after femoral nerve block complaining of persistent numbness in their thigh. They can have falls because of quadriceps inhibition. And so this flyer came out, although looking at it in retrospect, it was block of the month. I think it might have just been a 1 month series. I've never seen any other blocks of the month, just this one. So, and I thought this was interesting. It was also at a time where a number of my assistants and colleagues were talking about injecting local, and the assistants saying, "Oh yeah, everyone's injecting a bit of local in the back of the knee." So I sort of started doing that. That's a good idea. But local infiltration analgesia is a bit more than that. And this is the paper that Dennis and Laurie published in 2008. And I guess I'd consider it a landmark paper because I think it is gradually but going to fundamentally change the way we practice orthopaedics. And they basically published really an observational series of 325 patients. They were able to show they had good pain control, but furthermore, they were able to get their patients up immediately after surgery. And they were able to discharge 70% of their patients directly home after one night. Now, I guess my initial sort of view of this was I wasn't necessarily so interested in getting patients out of the hospital, but I was interested in getting good pain relief and getting the patients up because I believe that early mobility reduces complications. So what exactly is local infiltration analgesia? So essentially, it's a systematic infiltration of this dilute mixture of ropivacaine, ketorolac and adrenaline. And it's large volumes, so you're using 150, 200 mils even, and you inject all of the areas that you've operated on. All the layers from the back all the way through to the front, including skin. And then you leave a catheter in there and you re-inject some hours afterwards. In their paper originally, they injected about 15 to 20 hours afterwards and then pulled the catheter out. But as I said, it's more than that. It is a philosophy. So it's not just about analgesia. It's also about getting the patients going so we avoid the complications of incumbency. And I'm sort of come to the belief that thromboembolism is really a problem of immobility. And if we get the patients up in the first sort of few hours or first day after surgery, then you can virtually eliminate it. And then you don't have to hit them with the heavy-duty heparin. It avoids the problems of pain relief, so the post-op nausea and vomiting. and all the other things I mentioned before. And as a side effect, a useful side effect, we can actually get our patients out of hospital earlier. So I'll go through the technique as described by Laurie and Dennis, and you're essentially using 50 ml syringes, or I use 25 ml, and a long spinal needle, and use a moving needle technique. So you don't inject one large volume in one spot. Michael Armstrong was sort of concerned about a patient who had a foot drop after hip replacement. And I think you do have to be aware of nervous structures, and you have to make sure that you do sort of suck back so you don't inject a large volume into a blood vessel. But I think that's pretty unlikely if you spread it around and you're just injecting small amounts in the area. And they also emphasised the need to inject several times during the operation. You don't do it all at once to minimise blood levels. They've both shown that blood levels are really not a problem. We don't tend to see huge blood levels of ropivacaine after this procedure. And this is the technique. So first of all, 30 to 50 mils into the posterior capsule. You then go to the sides and inject 30 to 50 mils around the median lateral collateral ligaments and into the fat of the anterior aspect of the femur, and then into the subcutaneous tissue. And then you put your catheter in at the end. They added some post-operative treatment as well, so they made sure the patient did have some breakthrough morphine if they needed it, but not ongoing parenteral opioids, no PCAs. They bolstered it with paracetamol and brufen, and there was oral analgesia ongoing. And then they re-inject 15 to 20 hours later, about 50 mils. And then they use compression bandings and cooling with ice packs to try and limit the spread of the local anaesthetic and to maximise the effect. And they had no serious complications, particularly no complications associated with ropivacaine toxicity. So the next thing I thought I'd do for you would be to look at the evidence, see what's been published about this, and there's been a fair bit. I thought I'd start with the anecdotal evidence. So this is a guy some hours after knee replacement sitting up doing a Sudoku, and before, when I didn't use this technique, the patients would all be sort of flat out, sort of unable to move and sweating and pain, and so I thought that was quite impressive. I deleted the video as well. The Scandinavians have actually taken this up with gusto, and apparently 70% of joint replacement in Scandinavia is done with this technique. So they've actually also done a lot of the research. So yes, they did show that it reduced morphine consumption the first 48 hours, so 18 milligrams versus 87, but less complications associated with the morphine. It's better than PCA. So with these graphs, the top graph is PCA, and the bottom two graphs, one is just local infiltration, and the second one is local infiltration with a catheter afterwards. And so it provides better pain relief and lower morphine use than better than epidural. So basically they found that the morphine use and the pain relief was better in patients who had this system other than compared to epidural, and the length of stay was reduced as well. And they concluded that it was superior pain relief, reduced morphine consumption, and safer. And then the femoral nerve block is probably the mainstay of a lot of people's treatment now, and it does seem to be as good or better than femoral nerve block. So this is another prospective randomised trial. And essentially in this group they found that they were equivalent. Morphine use was less with the local infiltration analgesia, but the pain relief scores are similar. But the conclusion was that it's probably better to use the local infiltration technique because it's quicker, it's simpler, and it's cheaper. And then just a quick slide to show that a compression bandage does actually help in prolonging the effect of the local anaesthetic. So how do I do it? I guess I do pretty much what has been described. You can get a poly bag, 200 mils of this 0.2% mixture, so it's dilute Narrapin. And generally, I've been concerned about injecting adrenaline into skin, maybe unnecessarily. So I've tended to keep some plain, and I've injected that more superficially. and I've kept 150 to mix with ketorolac and adrenaline and use that deeper. And there can be some institutional problems doing this, because somebody's got to inject the pain mixture the following day, and if I'm not around to do that, I did find that I could set them up with a pain pump to either trickle some local anaesthetic in there, and this ambient one allows you to do a bolus PCA, so a simple system that takes the nursing staff out of it. But you can actually just inject it straight into the catheter. Personally, I have had one patient who developed a wound breakdown after a union, and that I think may have been related to the technique. I probably injected too much local anaesthetic in and around the skin. Obviously, wound problems with unis are very rare. They generally heal up pretty well. And I've had a few patients with blistering of skin. So I think you've got to take care with adrenaline, take care with the volume of local that you put into the skin, and also sort of where and how you inject it. And I'm grateful to Laurie, because I had a chat to him about this yesterday after his talk, and he said, just be careful where you inject. So don't inject right into the intradermal layer. So if you're raising a peau d'orange type thing, then you're too superficial. You've really got to get deeper than that. He also felt you didn't need to inject the lateral skin, because it's already anaesthetic, as we know. And that skin that's distal and medial, which is the poorly perfused, we probably should take care to avoid that as well. And he also recommended, pretty much like you do an ankle block, you raise that sort of bleb across the front of the distal tibia. Well, you can do the same across the front of the thigh, and that'll pick up the superficial cutaneous nerves as they come down, and that's probably a safer way and probably a more effective way of doing it. Some controversies. I guess some people are injecting, I'm not sure whether it's methylprednisolone, but steroid in the mixture. I haven't done that. I know Laurie's injecting steroid, and that reduces swelling, but I've been concerned about infection. People worry about the catheter being a cause of infection, but the same sort of people will put a drain tube that's about 500 times the size and leave that in for a day or so. And these catheters are tiny. Plus, they've got a filter that filters out very effectively microorganisms. So I think as long as you use the filter, the risk of infection from these is very low, or not related to this. And the final controversy is early discharge, is whether personally you believe that we should be pushing patients home in the first day or two after surgery. And finally, sort of put a slide in to sort of talk about, well, how do we introduce this? Because I think that's the difficult thing, because it does require a whole paradigm shift, and these are the people that you have to actually get on side. So you need to sit down. You don't just sort of announce you're going to do it. You've got to sit down with your anaesthetist and talk them through the whole system, and introduce it slowly and carefully with education for nursing staff, physiotherapists. And there is resistance, because there's a whole system built up around medicalising joint replacements that we have to break down. So in conclusion, I think it's safe, I think it's effective, and it's cost effective, and I think it's probably in the next decade we'll probably all be using it for all of our joint replacements.
Absolutely perfect timing there, James, right on the money.